Let's study disease control guidelines in HICP.
Now we will see outbreak definition. So it is a occurrence of two or more epidemiologically related infections caused by organism of same type relating to place and time is defined as outbreak. So there are main two types of the outbreak. One is common source outbreak and second is propagated outbreak. So in common source outbreak there is a common source, so like contaminated food or water. So in that subtypes are one point source outbreak, so it is of short duration, example food poisoning in the party. Or second is continuous common source outbreak, so it is of long duration, example contaminated water supply from tap water or from well. Then third is intermittent common source outbreak, so it is intermittent exposure, example industrial contamination. And the second main type is propagated outbreak, so there is no common source in that and the outbreak spreads from person to person and then it causes epidemic. Now we will see steps of the outbreak investigation. So there are total 13 steps. So in step 1 you have to prepare for field work, so confirmation and verification of the diagnosis is there. Then second step, recognize the outbreak and prepare to investigate. So establish existence of outbreak, determine if immediate control measures are needed, then notify and communicate, and formation of outbreak control team. Then step 3, verify diagnosis and confirm the outbreak exists. Step 4, construct a working case definition. Step 5, find cases systematically and record information. Step 6, perform descriptive epidemiology with respect to time, place and person. Step 7, develop hypothesis. Step 8, evaluate hypothesis epidemiologically. Step 9, reconsider, refine and re-evaluate hypothesis. Step 10, compare with other lab or environmental studies. Step 11, implement infection control measures. Step 12, initiate or maintain surveillance. Step 13, communicate findings. So communicate in the hospital or prepare the final report. So in post exposure management there are few steps. So first step is first aid. So then second is report to designated nodal center. Third is take first dose of PEP for HIV. Then lab testing for bloodborne viruses. Then decision on PEP for HIV and hepatitis B. Documentation and recording of exposure. Informed consent and counseling. Follow-up testing and precautions during follow-up period. What do you mean by exposure? So it is exposure to the blood or body fluids because of the injury by injections or catheters or any sharp object like scalpel or forceps. So let's see one by one. So first is first aid. So what to be done and what to not to do. So first in do's, so for sharp injury, immediately wash the wound and surrounding skin with soap and water followed by thorough rinse. For splash, irrigate the site thoroughly with water at least for 5 minutes. In do not panic, do not place the pricked finger into the mouth, do not squeeze blood from the wound, do not use antiseptics and detergents. Second is report immediately to the designated nodal center. So report to be to the duty casualty medical officer CMO. Then evaluation of exposure risk. Provide PEP, that is antiretroviral therapy for HIV, for hepatitis B virus vaccine or immunoglobulin. Then facilitate laboratory testing for hepatitis B, HCV and HIV. Then maintain the record of needle stick injury. Then third is first dose of PEP. It should be taken as early as possible. Maximum effect will be there if it is taken within 2 hours of the exposure. Then recommended PEP by NACO is single tablet of tenofovir 300 mg plus lamivudine 300 mg. If source HIV test report is documented and is negative, then no need for the first dose of PEP. Then fourth is testing for bloodborne viruses. done for both healthcare worker and for the patient, that is source. It should be done by rapid methods. The tests done are anti-HIV antibody detection by tri-dot method usually, then hepatitis B antigen detection test, then anti-HCV antibody detection. Anti-HBs antibody is done for healthcare worker if previously vaccinated. The decision on post-exposure prophylaxis. So for HIV, it depends on the type of exposure, like mild, moderate, severe, and HIV status of the source. And for hepatitis B, it depends on the hepatitis B vaccination status and protective antibody titer of healthcare worker, and hepatitis antigen status, positive or negative, of the source. So this is a chart showing in exposure code and source code. So if the exposure code 123 and source code negative, then PEP is not recommended. If exposure code 1 and source code 1, then also PEP not recommended. Exposure code 1, source code 2, PEP required, that is tenofovir 300 mg and lamivudine 300 for 28 days. Exposure code 2, source code 1, PEP required for 28 days. Exposure code 2 and source code 2, PEP required, tenofovir 300, lamivudine 300 for 28 days. Exposure code 3, source code 1 or 2, PEP required. Exposure code 2 or 3 and source code unknown, PEP required. For hepatitis B, if healthcare worker has taken 3 doses, then it is not required. Non-responders after 6 doses, then you have to do hepatitis B surface antigen test, and then hepatitis immunoglobulin 2 doses are required. For 3 doses of vaccine, hepatitis B test positive but anti-HBsAg antibody test less than 10, then hepatitis B immunoglobulin 1 and revaccinate. If antibody test is less than 10 titer and HBsAg negative, then no need of immunoglobulin or vaccine. If antigen test is plus minus and antibody titer more than 10, then no need of the immunoglobulin or vaccine. In unvaccinated, HBsAg positive but titer is negative, then immunoglobulin 1 dose and complete vaccine schedule, that is 016 to be taken. If the test negative, anti-HBs antibody negative, so no need of immunoglobulin but complete vaccine, that is 016 to be taken. Then 6th step is documentation and recording of the exposure. So structured pro forma is there for collection of detailed information: date, time, place of the exposure, type of procedure done, type of exposure, duration of exposure, exposure source and volume, type of specimen involved. Then 7th step is informed consent and counseling. So to relieve anxiety of exposure, to inform about risk and benefits of PEP, the exposed person must sign a consent form for prophylaxis treatment. Then 8th step is follow-up testing. It is necessary if the source is positive or unknown. Clinical follow-up, monitoring for development of signs indicating HIV seroconversion, usually within 3 to 6 weeks after the exposure. Laboratory follow-up for HIV testing, follow-up at 6 weeks, 3 months and 6 months. For HBV and HCV, 6 months after the exposure. Liver function test at baseline, start of PEP for HIV. Complete blood count and hemoglobin estimation baseline should be done then at the end of the 2nd and 4th week of the PEP for HIV. Precautions during follow-up period. So refraining from blood organ semen donation, should not donate any organ or blood or semen. Then safe sexual practices till both baseline and 3 months HIV tests are found to be negative. Then seek medical evaluation for any febrile illness that occur within 12 weeks of the exposure. So reduction of transmission of hepatitis B virus from healthcare worker to patients by more vigilant screening of hepatitis B virus in healthcare workers, then hepatitis B virus vaccination in healthcare workers, practice of standard precautions, restrictions of practice of infected healthcare worker from exposure prone procedures, and awareness of healthcare worker to avoid EPP, that is exposure prone procedures. So if hepatitis B positive healthcare worker is there, then according to CDC guidelines, the 2012, what are the things to be done? So first, no restraining from the work. So he can come for the job, but then what precaution he has to take? So standard precautions like wearing of gloves, apron, mask, cap, and then plastic sheet, apron. Then use safe needle device, example blunt needles. So he has to use blunt needles. Then personal protective equipments like double gloves he should wear. Then avoid unnecessary phlebotomies. Then avoid unnecessary intravenous catheters. Cover exudative lesion till it gets resolved. So if he is having any exudative lesion, any discharging abscess or sinus, then it should be covered. Then investigations for infectivity, that is hepatitis B virus DNA and HBe antigen testing should be done for the infectivity status. Then the expert review panel, so evaluate positive healthcare worker clinically and by viral load, assess practices and procedures, then counseling of exposure prone procedures, and advise precautions to be followed. So these are the things we have to do according to CDC guidelines 2012 for the hepatitis B positive healthcare worker. So in this chart we will see if the viral load, that is hepatitis B, hepatitis virus B virus DNA, if it is less than 1000 and if it is more than 1000, so what to be done? So if the hepatitis B virus DNA is less than 1000, so that healthcare worker can perform exposure prone procedures category 1 and 2. So now we will see what is 1. So in category 1, these are the high risk procedures. So major surgeries, major injuries like hysterectomy, delivery, LACS, vaginal delivery, oral surgery can be performed. If hepatitis B viral DNA load is more than 1000, then can perform exposure prone procedures category number 2. So now we will see what is the things can be done in category number 2. So these are low risk procedures. So other surgeries other than major surgeries, then use of needles when hands are outside the body, then phlebotomy like phlebotomy, IV lines, medication by injections. So in that hands are outside the body. Needle biopsies, lumbar puncture, minor dental procedures, insertion of tubes, endoscopy, internal examination with gloved hands, that is vaginal, oral or rectal, then external examination like temperature, pulse, blood pressure, respiratory rate, eye examination can be done. So in less than 1000 the load of the hepatitis B virus can perform both the categories procedures, that is high risk and low risk, and if the more than 1000 is there, then category number 1 is not advised, so only category number 2, that is low risk procedures can be done.
Antibiotic stewardship provides strategies for rationalizing the use of antimicrobials in the hospital. CDC has defined antimicrobial stewardship as the right antibiotic for the right patient at the right time with the right dose and right route, causing least harm to the patient and future patients. Indian statistics on antimicrobial resistance due to absence of central monitoring agency. Indian statistics on antimicrobial resistance not clear except for M. tuberculosis and leishmania. Antibacterial resistance to S. pneumoniae is now a global problem in India. The strains are still sensitive to penicillins, macrolides, and fluoroquinolones. Multi-drug resistant enterobacteriaceae are common. Consequences of antimicrobial resistance, serious complications for elderly and children, compromised therapy of human infections, increased length of therapy and more doctor visits, prolonged hospital stay, and significant increase of treatment cost. Bacterial resistance is a major threat to public health. Inappropriate antimicrobial use, lack of quality control in manufacturer or outdated antimicrobial, inadequate surveillance or defective susceptibility assays, poverty or war, Use of antibiotics in foods. See antibiotics for viral infections. Antibiotics sold without medical supervision. Spread of resistant microbes in hospitals due to lack of hygiene. Control of resistant bacteria. Do not indulge patient demands for unneeded AMA. Educate patient on appropriated AMA use. Identify the pathogen. Choose appropriate duration and spectrum AMA. Combination therapy. Complete full course of therapy. Use AMA prophylaxis prudently. Follow proper hygiene during procedures. Search for the source or cause of spreading of infection. Encourage patient to get vaccinated. Improve resistance surveillance systems, use antibiotics judiciously in non-human settings, advocate new drug development, gene therapy, querying antibiotic policy, and monitoring antibiotic use in hospitals, restricting use of third and fourth generation antibiotics, rational empiric therapy based on susceptibility data from microbiology hospital, implementing antibiotic stewardship in critical care units.
So, Hospital Infection Control Committee is constituted to plan, monitor, evaluate, update, and educate healthcare worker on standard infection control practices. The scope of this is 1. The meet periodically to evaluate infection rate in hospital. 2nd, monitor infection control practices. 3rd, look at infrastructural corrections required to prevent spread of infection. And 4th is the detect hospital outbreaks of infection. The components of HICC: first is medical superintendent, second is medical MD in microbiology, then third is ICN, that is infection control nurse. So the function of this infection control nurse to visit all areas of patient care like operation theatre, CSSD, laundry, biomedical waste to monitor practices. Then the next component is head of surgery, head of medicine, then head of housekeeping, head of kitchen to prevent foodborne infection outbreak. So infection control officer is a MD microbiologist, and just now we already saw the role of the microbiologist. So these are the duties of the infection control officer. So the duty is to communicate, coordinate, then keep the track of developing outbreaks, and then participate in research activities, and main developing the guidelines for appropriate collection, transport, and handling of the specimens, then laboratory safe practices, perform antimicrobial susceptibility testing, and then giving the summary report of the antibiotics, and monitoring of sterilization, disinfection, and environment practice is wherever necessary. So these are the main duties of the infection control officer. So the selection of infection control nurse is selected through the following process. So any staff nurse who can volunteer to enroll for ICN, or nominated nursing staff can be enrolled, or all staff nurses have to undergo written exam provided by surveillance and infection control division, and only staff nurses scoring more than 90% of marks shall be enrolled as ICN. So according to the hospitals, there are different selection criterias. Now we will see what are the definition of infection control nurse. So this ICN is a registered nurse with additional academic education and practical training in infection control, clinical and diagnostic microbiology, epidemiology, and computer technology. So the duties to the ICN is a bridge between HICC and wards and ICU. So the ICN should go on rounds and visits all hospital location, control and monitors these healthcare workers for the infection control measures, then identifies the problems and implements appropriate measures, then collection for healthcare hospital acquired infection surveillance, hand hygiene audit, then PPE audit by daily visiting, then implementation of transmission based precautions, disinfection policy, high risk areas environmental surveillance, education of healthcare workers and patients, provide post exposure prophylaxis for needle stick injuries and maintenance of the registers, then staff vaccination program for hepatitis B virus and influenza, and involved in antimicrobial stewardship activities. So these are the duties of the infection control nurse. Hope you find this session useful for your understanding and for your exams. Thank you.